Hello, welcome to the program Effective Management of Patients with GI Tumors in the COVID-19 Era. This is the fourth module of a 6-week series and is an expert roundtable. Today's session is approved for 1 hour of CME, CNE, CPE, AAPA credit. The series is provided by North American Center for Contributing Medical Education, an HMP company, and supported by educational grants from Merck and Pfizer. My name is Axel Gothi. I will be the moderator for today's program. I'm the Director of GI Oncology Research at the West Cancer Center and Research Institute in Germantown, Tennessee. I'm joined by Dr. Stephen Pergham, who's Associate Professor for the Vaccine Infectious Disease Division at Fred Hutch, the Cancer Research Center in Seattle, Washington, where a lot of things that we talk about today started. Second, we have Dr. Alberto Sobrero, who's the head of the Oncology Department at Ospedale San Martino, University of Genova in Genova, Italy, and Dr. Kathy Eng at Vanderbilt Ingram Cancer Center. She is the GI Oncology co-leader of the Gastrointestinal Cancer Research Program in Nashville, Tennessee. Okay, so welcome all of you. Let's begin. We want to cover some epidemiology aspects of the COVID epidemic right now, or pandemic, and the impact of this pandemic on our patient care, what we really experience in real life. And I'd like to talk to Steve first, who's really kind of in a place where one of the first hotspots emerged in the United States. And I'd like to see, what was your initial contact with COVID, coronavirus? And tell us a little bit about where we are right now epidemiologically and what the trajectory looks like in various parts of the country and the world.
Yeah, so thanks for having me. I appreciate it. Obviously in Seattle, we were at the forefront of this just because of what happened in Washington State, but my colleagues in Italy and across the country have had to deal with this, and certainly around the world. So I think I was really aware of this actually in January because I'm on Twitter, and I've been following, and I'd seen a report early that this there was a small cluster of pneumonia cases in China. I'd been following very closely with it. And then we were lucky enough to have a clinical trial here where we were scanning people in the community for positivity, and we identified a case that was linked to the initial location where the first patient in the United States was positive, which indicated that there was community transmission at the end of February. And that was really sort of a wake-up call for all of us to start getting ready. We knew there were more cases based on some initial modeling data that suggested that our community was going to need to be prepared. So we sort of had, similar to what many of you were doing, we reached out to our colleagues in Italy, our colleagues in France and England and in China, actually had conversations with the physicians in Wuhan about how they approach this. And so really we set up a number of different steps. One was to start thinking about how do we modify our care? So how do we shift the number of people who are on campus to being off campus? We really shifted our thinking in terms of providing resources for testing really early, and really organized a specific effort to develop PPE strategies for people who are coming onto campus to be prepared. And that included a number of things. It was pre-phone calls for patients who were coming into clinics. It was developing offsite locations or drive-up clinics for patients who could get tested prior to coming to campus. But, frankly, a lot of that just changed over time because policies and procedures nationally changed. And we learned from colleagues around the country of their experiences as well. So there were a lot of different things that really you need to be nimble. And so, when we had our first cases in cancer patients, then we made different changes. When we saw changes in the community and rates go up, we modified things again. So I think the biggest thing that we really wanted to do was to make decisions, to be really moving forward with those decisions and just using that decision and then making another decision based on sort of the ones we'd made prior. That the worst thing to do was to stand on the side and be paralyzed by that worry. And so I think that was really helpful for us. And frankly, early on in the end of February, we got our incident command structure organized within the center and got everyone on the same page. So it was really important to get all of the different subgroups involved and say, okay, what trials do you need to have open? Which ones do you not need to have open? Who needs to be coming to campus? And giving it to the oncologists specifically to say, tell us about your experience and tell us how you can modify your care to have less people on campus, and where and who needs to be on campus for surgery or other components that we need to build on. So was a lot of internal discussions on a regular basis with this in making decisions about how we kept the center open and functioning during the period where we had COVID at higher rates in the community.
Can I just, you mentioned you tested patients. When did you have your tests available, ready to PCR-based tests?
Yeah, so we were really lucky. We had been talking about this because of awareness early on. That we'd worked with our virology lab to have a test available, and we had a test available rapidly within the early part of March. And even in the late portion of February, we were really ready to go. So we have had adequate testing for a while. We didn't necessarily have the amount of testing we wanted initially, but that's really rapidly moved up. I think they can do upwards of 6,000 to 7,000 tests a day within the lab. So we're really have quite a high capability. But that's been an issue across the country because not everyone has that. And we were really unique because we had a center that had focused on this early and had FDA approval to do this on an early basis. But for a lot of places, when they're using other resources like LabCorp or other send-outs, the delays in getting those results is hugely problematic.
I just heard today in our center, we send out to AAL, it takes 7 to 10 days turnaround time. And then, of course, you cannot isolate and track, because,
No.
it's delayed. Alberto,
right.
In Italy, when did you start testing patients? When did you feel the first, had the first cases identified?
Say by mid-February, we started getting alerted. And I remember I was already tested as a doctor, still practicing 100% of the time in oncology by mid-March. And that was because of a few patients coming in, being tested and being positive. I have been tested 3 times. So the first time was early March. The real tough times in Italy started on March 10 to 15, when things got out of control, essentially. My division was shut down, and we were actually, we were referred to the other 2 divisions of oncology simply because our location was building of infectious diseases. So it was obviously a very sensible thing to do. What else? The worst condition was by April 1st, I would say, when essentially we got paralyzed because of absence of directions, number one. Everything was happening. There were no clear rules on whom to test. The only clear-cut rule was that visit only those patients who you evaluate as impossible to defer. Otherwise, they will get severely damaged by the fact of not being taken care of. At the same time, I noted something that is really unusual for Italy. It happened a couple of times in history, and that is a very swift change within the population. They became very respectful of all the rules, the few rules that locally were adopted. There were entire small cities where cancer centers were completely shut down, no longer existing for at least 3 months. And still there was an adaptation by population. Even from the first lockdown order from the government, usually we do not believe in government, we do not trust them, we are not cut out to follow rules, okay? I can only think of the helmet rule and the smoking law, the 2 good examples that were extremely tough and yet taken so easily by all Italians, which are exceptions. And in this case, the same attitude was developed. At the same time, there was a sort of a surge of respect to doctors. I never felt so respected by my patients. Okay, but in this condition, it was very sweet, I would say. And at the same time, the fact that they respected the rule, for example, of only one person coming in the visiting office. That is outstanding, incredible for Italians, because usually you get 4 people in the room, and the patient is the one who speaks less frequently. So no, well, that's classical in the Mediterranean as well in the Middle Eastern countries. Okay, so I was shocked by this adaptation.
But Alberto, when I look at the curve, I mean, you had a very high, overwhelming peak, but now, like other European countries, things are a lot better. I mean, you know, the daily infection rates, mortality is very, very low, and it's a really nice example how this actually worked. You know, if you really obey rules, and that is something which I don't know. Kathy, what do you think? Do Americans like to obey rules here? I mean, it's not just a Mediterranean thing, I guess.
So now I feel like we're almost Italian. So we are not good about, in the United States, from what I can see thus far. I think that in general, people were obeying the rules originally when they saw what was happening in New York City. They saw the significant morbidity and mortality associated with it. And I think just the unknown. Now, because I think some new approaches have been identified, I think because some people feel that others know how to treat these patients, even though obviously some patients unfortunately end up dying. I think they think that they don't necessarily need to obey the rules because we know some more now. And a lot of people, I think, are also getting restless. So especially a lot of the younger generation, I mean, you can see them on the news where they're going
and on the beach, you know.
Yeah, going out to the beaches, bars, restaurants. There's no social distancing. And then unfortunately, in the United States, a mask has become a political item. So people are not really thinking about the actual impact of their contact and who it will impact, whether it be someone at work, family, or just somebody that's in just brief contact with them, maybe at a local store, grocery store or something, and the consequences. So unfortunately, I think in the United States, we're not doing the best job in regards to following up on the rules and really recognizing the fact that this is not going to go away anytime soon.
Yeah. So Stephen, when I saw the curves in the daily, you know, positivity tests, you know, I think we had our lowest rate on June 1st around that time, and now we're actually exceeding 60,000 cases a day. You know, this is close to kind of what Wuhan had in the whole time. We have one Wuhan a day.
I mean,
it's just incredible.
Yeah, I mean, we're way beyond where Wuhan was. I mean, we've had incredible numbers here. Unfortunately, and you know that is partly due to the size of our country, but it also shows the disparate ways that different states have managed this, and that's unfortunate because some states have been really progressive and thoughtful about how to do this, and have been focused on you know, lockdowns and caution. But even a place like California, which I think did a great job and had a lot of focus on this, is still dealing with a large outbreak in LA. And so, you know, I think there's some aspects of this. There's a little stochasticity where it's sort of random happenstance where sort of these outbreaks happen. You wonder, as an example, why Rome wasn't more affected than portions of northern Italy. Sometimes it's just sort of luck. At the same time, I think some of the differences in why we're seeing this, I don't really feel like the first wave is over. I think basically this is a continuation of the wave. It was just a lull that made people feel more comfortable. Yeah, and now we're seeing this big increase because a number of states opened too quickly.
But
and I think
also, I mean, in contrast to China and Italy and other places, we do not limit travel within the United States. You can still go to California. You can go. There are certain areas of Italy which were completely locked down, and you know, and same the Hubei province, you know, was completely locked down. There was no travel in and out. which we have never done that because it would be against the rights of Americans to move freely, whatever. Yeah.
Yeah, I mean, there are those challenges for sure. I mean, we have some limitations because, I don't think it would be acceptable
Right.
if you put those kind of restrictions on. We've already seen the masking mandates and others have been very difficult for people to accept, as Kathy said.
It's interesting when you talk about the numbers again have become political. It's not just mass, how to interpret the numbers. Do we see cases go up because we test more, which we know it's not true. We have more hospitalizations, etc. So, and it's really hard to have a discussion without being pushed in one political arena, because I think facts matter, and facts have become politicized. So that's it.
Can I just say one thing?
Yeah.
I am a bit concerned, though, what I'm hearing, at least from other people, is that you're having young people now that actually test positive, and they're quite ill, but they still are not going to the emergency room. Whereas I think when it was more unknown, they would have gone earlier. And now it seems like a lot of them are just staying at home and suffering at home. And I'm very concerned about that, because we're not capturing those patients then that should be hospitalized, in fact.
Right. Stephen,
go ahead, please.
Let me direct the discussion a little bit because we need to talk about impact on GI oncology and what they happen. But I want to get your experience in terms of number one, what makes people sick? What's the percentage of asymptomatic carriers, which I think is very important, and why do people die? Because from what I understand, there's the infection, but there's also the immune reaction against the infection that can contribute to mortality. And I'd like you to, from your standpoint as a virologist, an infectious disease specialist, talk a little bit about, how many patients percentage-wise are asymptomatic, and and what really kills people.
Yeah. So really interesting questions. I'm not sure I'm going to have the best answers for you, but I'll do my best. I think let's focus on what kills people first. Clearly, it's a combination of the virus and the immune system. And I think the virus does some really unique things. It involves the endothelium and can lead to a lot of clotting disorders, which can be a large problem with patients. We've had stories of people who have gone to the OR to get a clot removed and had it removed and then immediately reformulate. It's almost a process that anticoagulation has not been can completely fix in some situations. And in some patients, they get severe inflammatory responses that lead to an acute respiratory distress syndrome, which really limits the ability to ventilate patients, even with appropriate high-level ventilation in the ICU. ECMO has been used in some of those patients, but again, that combination of inflammatory responses to a novel virus, I think, is a major issue. We've seen some responses where there's a study in dexamethasone. We're using dexamethasone in England, which suggests that maybe using that early can help mitigate some of these long-term responses. But we've also seen benefits from antivirals like remdesivir that may help prevent additional issues. So I think it's really going to be, when you're thinking about death, I think it's a combination of the two things. I think it's high viral load and it's a really robust immune response. But in some immunocompromised patients, we've had really bad outcomes, or there are bad outcomes in immunocompromised patients. You don't think about their immune system being as robust, but they certainly can get very ill. And the numbers in cancer, if you look at the CCC19 paper in Lancet or others, the rates of mortality are higher than the general population. So that's not unexpected. But what's interesting is a lot of that may not be related completely to immunosuppression, but it may just be related to who our cancer patients are. They tend to be patients that are older. They tend to have comorbidities, and many of them, are just not as healthy as what the standard population is. So I think it's partly related to that as well. But I think so. That's one thing. So I think when you think about the death, we don't know exactly. I can't give you a marker that says these are the patients that are going to die. These are the patients that are not, because we've had patients that do fine, and then on a dime will become very ill and need to be intubated. And so that can be really hard to determine. But I think it's a combination of viral load and the immune response that probably plays a bigger role. And then I think Kathy's point is really important, is that some of these patients are not coming in early enough, and they need to get evaluated early. because they can be helped in those early phases. And so particularly people of color and those in underrepresented minorities and socioeconomically challenging groups, they may not have the capacity, may be worried about coming into healthcare. They may be people that maybe don't have access to healthcare or really have a primary care doctor where they feel comfortable addressing this. And I think that's a real focus we need to spend to get these people in. And those are a lot of people who unfortunately are also predominantly affected with late stage, colon cancer and other GI malignancies. So I think these are important groups that we need to spend some time on. And then your issue really quickly about, about, I think you were asking about transmissibility, I think.
The asymptomatic transmissibility.
Oh, yes, asymptomatic. So there's been assumptions, modeling studies that have suggested somewhere around 40% of transmissions are related to asymptomatic people, can be even higher in some. But I really break asymptomatic people into two groups. One is an asymptomatic person who truly is asymptomatic, never develops any symptoms ever at all. And then those are people that are probably less common in general, and they're probably less likely, we think, to transmit the virus overall. Probably the more common group is people that are asymptomatic at the time of exposure, where you can be 1 to 3 days prior to your illness, where you develop symptoms, you can be actually shedding high levels of virus. Those are the pre-symptomatic people who develop this and then go on to develop symptoms. And we think that's probably a bigger group that are shedding and necessarily infecting people, because we do think that people, as they're getting sick, are sort of isolating themselves a little more, but it's those early phases that we think that some of those major transmissions are happening. I think a lot of the major outbreaks and things that we have been seeing may have been related to that, but I still feel like the symptomatic person who's out in the community is the biggest risk. So the person who is coughing and sneezing, who's out in public, who's creating droplets on a regular basis, is the biggest risk for transmission to any population.
Right, no question about that. Kathy, Alberto, anything to add or ask Steve?
I think he's done a wonderful job of kind of providing a broad overview and really showing the concerning patient population.
I agree. So Steve, the one thing that I need you to answer here for everyone is, when will we have a vaccine and which company will produce it so that I can buy stocks right now?
Yeah, right. I'm not gonna comment on stocks. That would be insider trading, I guess, right? No, I'm joking. I don't really know. I think there's some great vaccines that are coming through the pipeline, or they're getting into phase 3 trials. And we're lucky at the Fred Hutch in the Cancer Research Center has had experience with the HIV vaccine trials network, and so is actually going to be one of the coordinating centers for these large vaccine trials, which is exciting. There are a number of vaccines. There's the Moderna vaccine. There is a vaccine that's, I think, I think it's Aventis. But there's a number that are coming. I think there's 4 that are moving into phase 3 trials. And I imagine that there's a lot of resources that are being put behind this. They're going to be enrolling probably larger numbers than most vaccine trials typically enroll. And there's a lot of discussion going on around that now. So I actually think it's possible that one of these takes, and there's some good phase 2 data that looks encouraging. And I think Anthony Fauci said this recently. He thinks it might be faster. I think we put a lot of our focus on this, and I'm hoping that it comes. The problem is it's not going to protect our patients. That's a harder question. We don't know how well it's going to protect immunosuppressed patients who are cancer patients. And generally the elderly who are older patients, they don't respond as well. But there's going to be studies that are going to focus on those groups too. And I know they're going to focus on underrepresented minorities and others in these studies. I know there's a lot of interest in that.
So when you're saying elderly, are you talking over the age of 65 or? Yeah,
so I should be cautious dating myself here. So I think the really high risk groups are going to be people that are 70 and above. Those are the people that, you look at people over 80, the mortality rates are substantial. Where in the 70s, they're high, 65 and older. Each time you're going down a generation, the risk of death and major complications goes down. But again, somebody who's 18 can develop severe life-threatening disease. So it is important that it's not, elderly are sort of a group that are, the geriatric population, however you want to describe it, but older patients in their 70s and 80s are really the highest risk. But I think if you're getting into 65 and 60, absolutely. People in their 50s and 40s are at risk too. So I think it's really a cross-generational. It's just the number of people who develop severe complications is increased the older you get.
So,
How
I mean,
strong is the
go ahead.
prediction that in October we will have a second wave of infection?
Yeah.
How strong is that prediction?
Well, I mean, it's hard to say in individual locations. I think the problem that we're going to run into is that I'm sure in locations where you are, if you look at serologic studies, the percentage of people that are positive is not to a level that we would consider that would be sufficient for herd immunity. So probably around 60% of people have to be infected. If you assume a R0 of about 2.5, I think the calculation is about 60% that you would need to have herd immunity. And so even in places where it's been really highly endemic, like New York, the rates of positivity are at most a little less than 20%. In Sweden, it's less than 20%. And so as people continue to travel and move around the world, as you saw with Wuhan started having reintroductions into Wuhan from places like Italy and Europe. And so that's going to happen across Europe as well as people continue to travel. Now, there are some restrictions. Obviously, Americans are not coming. There are some restrictions for Americans to travel to Europe, but there are European citizens who live here who have the ability to travel and go back to Europe. So there are things that are going to happen. I mean, there is a large outbreak in Israel at the moment, and how does that have an equivalent effect? And there are major gaps in areas that we don't understand. I mean, we know that India has a major problem, and we know that Africa is a place where we just don't have enough data, and that these may be hotspots that are developing. And these hotspots are going to develop around the country and around the world, where we're going to continue to sort of see this transmission around. So I envision that unless a vaccine is really effective and is available, that we're going to be in these situations where we'll have these, waves. Maybe it'll be a wave where you'll have it go away or relatively, but I think it's more likely you'll have low levels for a while, and then you'll have these spikes with a cluster or a major outbreak. So particularly during respiratory virus season, I think there's a lot of concerns about that.
I mean, I think everyone has the Johns Hopkins, COVID website, bookmarked, and I look at it right now, 12 million cases confirmed worldwide, 3.15 million cases in the United States. So it's still 1% of the population has tested positive. So we're far from herd immunity. I mean, no question about that. When I see the projection, it's almost logarithmic, that goes up in the world, in countries like India, Brazil. So this is going to stay with us. It's going to impact our care until we have a vaccine, or reach herd immunity throughout, really by having this virus go through our population, which I hope won't happen. So we will need to we need to deal with this, and it will have impact on our cancer care for the very foreseeable future. Cancer care, how we educate each other, communicate to each other, all the conferences have been canceled. And I do believe that one of the major conferences for GI oncology, ASCO GI in January in San Francisco, will likely not happen as a face-to-face meeting. It is sad to say, but it's just reality that we have to prepare for that. So, one thing is, of course, Alberto already talked about shutting down departments, really only limiting exposure to the people who are really in need, in terms of, have curative intent for, for cancer patients, etc. Kathy, what about research? Because, is research essential, or is research something that we can, delay, defer, whatever? What happened in your place?
So I can tell you what happened in our place. We actually did close down our research enrollment for about a month. Patients that were already on clinical trials were still followed regularly. We also reduced the number of research nurses available, and they would rotate, so there weren't too many people on site. And then we gradually reopened the research enterprise, but in phases, just very much like the city. Obviously, those protocols such as phase 1, with lots of additional blood work, or any that required an overnight stay, those were the last to reopen. Those that were the easiest that didn't have many additional tests, like a phase 3 study, or those would reopen first. So we were closed fully for about a month, but we didn't shut down to the existing patients on clinical trials. I have heard about other centers that they completely shut down. Even if you were on a study, supposedly one patient told me she was taken off temporarily. So I do find it a bit interesting how everybody else views it. Here, our diagnostic imaging department continued in the same fashion, but I know that wasn't the case for everyone, everywhere else. In general, we are fully up and running right now. I would say clinical research, obviously, it's imperative to the care of our patients, and especially for our surgically unresectable patient population. They need clinical trials.
Alberto, what about Italy? I mean, you said, was it a shutdown completely, or similar to what Kathy said?
Much worse than what Kathy said, because we had a complete shutdown of research, and we still have the complete shutdown of research except for patients on study. Although those were, the management of those patients was simplified and not caring for major violation of the protocols. Most of the times the protocols make no sense. I wonder sometimes these clinical research protocols are unethical because they expose the patients to so many useless tests that lead to a delay in the validity of the staging test, so that he has to repeat the CT scan. I mean, it's a crazy word. So actually, I see this as an opportunity, given the fact that these are special times, and under special times, horrible things can happen. However, sometimes there can be some acceleration toward a more holistic interpretation of what is ethical and what is not. Another good example is that I have received several feasibilities, but because the trials were not so essential, but simply fine-tuning type of trials, I said, no, that's a waste of resources, essentially. Some time ago, the Declaration of Helsinki had a point out of the 22 points saying that if a trial is a waste of resources, then it is unethical. Okay, which deals with sustainability. Now, when you are in deep crisis as we are now, I think these issues should be brought up again to the regulatory people, so that the amount of paperwork is limited. We just submitted a phase 2 study, investigator initiated, but they were relying upon 2 different drug companies. We sent out a 70-page protocol with a 5-page outline. Now, after 1 year, we have ended up with 190 pages protocol. And that makes no sense, because you bury the key information in an ocean of useless regulations, essentially.
Yeah,
so
I think Steve, Steve, you were nodding it a couple of times, and I believe, and I think we all agree that there is an opportunity to move things forward in a better way. You know, crisis can create creativity, and we can do better.
Yeah, I mean, you've seen it with telehealth as an example. I mean, all of us have embraced this, and now it's become part of the lexicon for how we can do this. We have always wanted to move telehealth forward, and now we're seeing it become a part of what we do. And we, you know, as an example, we've used the ability to do tele-consenting, which is actually very helpful for patients, because they can interact with us, do a consent, and not have to be on campus. It's great. It's actually a huge benefit from their perspective. So those kind of things, I think, are really opportunities. But I completely agree with my Italian colleague that some of the regulations that have been put in place for patient safety are important, and we can't put those aside. But we have to be thoughtful about how we do clinical trials. So, you know, particularly for places, you know, like Dr. Eng has in Vanderbilt, where you have people traveling large distances to come to your center to do these trials. Is it ethical to bring them back when there's large outbreaks, or there's potential risk for them during those travel events? I think those become challenging. And I think, you know, that kind of approach, I think we need to sort of push the FDA a little bit to sort of think about what are the critical pieces of these clinical trials. And it's easy to add more. It's always easy to add more tests. It's easy to add more labs. It's easy to add more visits because safety is always the issue, and research is important. But I think we need to start thinking about the sort of burden upon patients and the potential risk in this current environment. I think it's critically important.
So let's talk about risk in terms of, when patients get chemotherapy, get procedures, because, Kathy, you said you opened up again, in spite of the fact that we're worse off than ever, and what are the risk mitigating strategies we're using? Is it like we're testing everyone, we're doing antibody tests, and it's not just for patients, but also for healthcare providers, I know that Tennessee government actually today issued a warning that we all should wear eye shields when we interact with patients.
Well, if you're in a I think it says if you're in a moderate setting, whatever that means.
Right, moderate setting, yeah.
Moderate risk, and I have to yet figure out what moderate risk stands for. I just read that as well today. I would say that basically we have every single new patient that goes into a surgical procedure or any type of elective procedure gets tested. Every single patient that starts as a new chemo patient gets tested. So we have been very active about on that for quite a bit of time actually already. Not all healthcare workers have been tested, in all fairness. I have not been tested yet, but I've not had any symptoms or any exposures that we're aware of. But anybody that has any potential exposure, they automatically get tested. And then we've done all the social distancing in clinic, in the waiting rooms. We've been very proactive. Our institution, I have to say, our leadership has been very, very proactive. They send us twice a week updates about what is occurring, any increases in the numbers, any policy changes. So we've been very, very, I think we feel very informed. And I think that helps bring confidence, not only to us, but to our patients that we're caring for.
Well, you have Tom Talbot and Dave Aronoff in your back pocket.
Yeah, I do.
So that definitely helps. Yeah,
that's definitely good.
I don't want to gloat, but yes.
So there's a lot in the CCC19, team is actually the whole data center is based at Vanderbilt. So there's a lot of awareness, at Vanderbilt and surrounding it. It rubs off to other areas of Tennessee, I can tell you that, which is good to see. I've been tested twice and I have an antibody test, and unfortunately I'm negative, so so Alberto, what about, have you had antibody tests? Because I know that that was one of those things to determine how much immunity is there in the population.
Yeah, however, the problem is that you don't know when you're positive or negative. That's what I've been told. So yes, I have been tested with swab 3 times and with antibodies twice. And because I was exposed several times to patients who got the COVID and actually died from COVID. So we have had several problems under this viewpoint. Essentially, the measures that Kathy mentioned were the same that we have used, except for the fact that we have reduced drastically the amount of, say, at all level of intervention in our practice, starting from the diagnosis, then staging, and then start of therapy, type of therapy, okay? We have changed our practice under these, under all respect. The best example is pancreatic cancer to me. I have seen 2, 3, 4, probably more pancreatic cancer masses, pancreatic masses with typical symptoms, CA19-9 elevated, maybe thrombophlebitis. And the question is, why do guidelines say that under these conditions, you should get a biopsy that 1 time out of 2 drags down the quality of life of the patient? So my counter question to the guidelines is, what are the chances that that case with these 4 characteristics is not a pancreatic cancer? And you know that in medicine, we practice a probability type of medicine, not possibility. And making a comparison with the jury trials, okay, our p-value is 0.05. That corresponds to is there any chance that you are wrong in this? And the level of this is 5%. So I think that a guy like that with those 4 characteristics do not have 5%, not even 5 in 1,000 chances of not having pancreatic cancer. So that's a good example where we didn't get the biopsy done, for example. Laparoscopic approaches in staging for gastric cancer, forget it, because if they go with a FLOT regimen and that they go onto a very nice response, you get the patient operated anyway. So I know that this is not done at the Royal Marsden in London, but again, we are under stress, and
But I think you have to make do with what you have and use your intuition. I mean, you have years and years of experience, and I think that's something that's really important, where you have to modify the treatment approach, because you usually know deep down inside if it's cancer or not cancer, I think. And so you have to modify what you can do to help the patient.
Yeah, I think, so there are a couple of things where I'm concerned about and a couple of things where I'm actually think, this is something we need to explore further. First of all, here, our major GI unit, didn't do screening colonoscopies anymore, and so there is this backlog of patients that we're expecting that eventually, will come with more advanced cancers, and I think there's some modeling aspects already, out there showing that patients will see more severe cases. The interesting thing, though, is, I was always, we all under the impression that, patients with myocardial infarction, PEs, whatever, non-cancer related stuff might even not go to the ER because they're too afraid to get infected. And we have not yet seen data that there's this huge surge of, let's say, non-cancer related or non-COVID related deaths that we experience, so somehow there's a little bit of a discrepancy. On the other hand, I completely agree with Alberto that we need to really come to Jesus moment. What is really important? What do we really need to do? Do we need to biopsy every little thing? Do we need to see patients back after every chemotherapy cycle? Can we do surveillance, with much longer intervals? What is the benefit of bringing patients back after a liver resection after every 3 months, for a CT scan? It doesn't have to happen. There's no benefit out there. So I think, really having a value assessment, what is really important for us in decreasing the contacts with healthcare facilities is very important. We've already seen modifications to regimens. I mean, who would give bolus Father-Few to Folfox right now? That's gone. I think that's gone. It's going to stay gone. We see shift toward oral therapies. We see, Alberto and I were involved in shortening the duration of adjuvant therapy, which, is all part of, what we're modifying, and we're forced to modify, but in a way for the better for our patients. And there are various different, so less myelosuppression, less visits, more oral therapies, telemedicine monitoring, and hopefully a lot will actually stay, and will not won't go back to what we did before.
Yeah, I think there is another general principle that jumps in the patient-doctor relationship here under these conditions. And that is the fact that we are kind of forced not to reason in terms of a categorical ethics that usually dominates the patient-doctor relationship in a one-to-one relationship outside the pandemic. Now we also have to consider a sort of utilitarian type of ethics. And that has to play an important role, because usually we take our decision based on patient factors, disease factors, and treatment factors. Now there is another factor here, and that is the community. It creates a sort of similar issue as the sustainability point, okay? That sometimes we practice an unsustainable type of medicine. Now we are in a condition where you have an extra determinant to take into consideration. And that is important. And I was surprised to see that patients understood. I kind of experienced a much deeper shared decision-making process with my patients, partly because I had a direct contact with my patients, because most of the times that is disturbed by the presence of relatives. Okay, so, but partly because the patient understood the situation. And that is fascinating, really fascinating from a psychological human perspective.
Very interesting.
Axel, can I just ask one question about the telehealth thing? So do you think ever at some point, for us in the United States, the whole licensing issue and coverage for telehealth, right? It's such a huge, huge matter. And we all take the same medical, we all have the same board exam. Where do you think this is going to go? Because there's so many differences that still exist, and how long will this telehealth waiver last?
Yeah, so I just did actually a course on telemedicine and licensing issues, whatever, because we're all affected by that. Right now, we're protected, at least there's nothing overtly against, consulting across state lines, because, that's really the issue, Alberto, that the licenses are state-based. So I have 3 state licenses and an allowance in Mississippi. So I can practice actually in 4 states, but telemedicine would benefit greatly from a national license. That is something which we really hopefully, one of those things that Alberto really said, crisis moments create opportunities. It would be great if we could do that. I promise not everyone will move to Seattle, or not everyone will move to San Diego, in order to practice medicine there.
No, but I do think I think this is important, because for all of us, we want something to be a silver lining in this whole experience. The pandemic needs to sort of lead to change. And I think the things that you're talking about and how we treat patients and how we look at clinical trials, those are 2 pieces. But I think telemedicine is one that I think what I have seen is really interesting interactions between patients that I've not able to have. There have been situations where we've talked about a really severe infection in a cancer patient, where the family's been able to be a part of a discussion where previously I'd never had that opportunity, because it was an individual who was there and the family couldn't come. Where others have been able to call into a call to learn what's going on from a distance and help with that shared decision making. Maybe a little more to the Italian model, where there's maybe sometimes more people involved than we want, but actually I think it's been really valuable. And I think patients are really going to clamor for this, because for a lot of people, I think about trying to park in Seattle is something that doesn't seem very important to people, but is a major issue in some places. And even the cost of parking in our cancer centers is sometimes a burden for patients. And so the ability to do things from a distance when possible is absolutely transformative for people to be able to seek care. And I think it's going to be really important. And I think they're going to I think the patient advocacy and the work around that is really going to help us to shift the narrative on a national level, from my view. But maybe I'm alone in that, but I bet you guys would agree.
Yeah, so I saw Alberto flinch a little bit when you talk about cost for parking in cancer patients, because that's something which is not necessarily an issue in some European countries. So that's the benefit of having a more comprehensive healthcare approach than the fragmented for-profit approach. Stephen, one question that I'd like to ask you, and I think we need to close off in our discussion, because it's been very, very informative actually. When we talk about the risk of cancer patients on therapy, it's clear from what I see that hematologic diseases, bone marrow transplant, those are very strongly associated with higher risk of mortality when you're infected with coronavirus. What about immunotherapy? Patients on immunotherapy, I've seen some data in cancer discovery where patients who are receiving immunotherapy actually a higher rate, death rate. Having said that, those were also patients with lung cancer, so it was not easy for me to tease out lung cancer versus immunotherapy effect. So what's your take on immunotherapy and risk of dying from corona?
Yeah, so I think probably the best data that I've seen so far is from Sloan Kettering in I believe that's a Nature Communications paper, or Nature Medicine, I think is what it is, where they sort of talk about their experience with immunotherapy, not hematologic immunotherapy, but immunotherapy agents like PD-1 inhibitors, et cetera, and that there is an increased risk. But again, most of these are lung patients, and so it's hard to sort of go beyond that. I think we just have to be cautious, because anything that stimulates the immune system in a different way could potentially lead to additional responses that could be detrimental to patients. So I think we're just going to have to collect more data on this. I mean, I personally cannot speak to episodes where we've seen this be a consequence of using these agents, but we've had limited awareness yet. It's interesting, in some of them, in some of these agents, there's actually some data that maybe they may be beneficial for some particular infections, but for this one in particular, because it does lead to hyperimmune responses, we're just not sure. And so I would encourage everyone who's listening to this, conversation, to start collecting this information on your GI patients. And I think this is a really great study that you guys should think about putting together on a national level to sort of answer some of these questions, because GI cancers are actually going to be at high risk for getting COVID, because they are people that, despite getting treatment, are out in the community and they're not hospitalized for long periods of time. They are getting therapy that is outpatient. They're often doing things where they can get exposed in high-risk areas, and they're high-risk populations. So I think this is going to be really important and something that you guys should be looking at really closely. I wish I had better answers. I'm concerned, but I think we need more data.
I think that's great. So before we wrap it up, Alberto, Kathy, any last words that you want to contribute and make people aware, or ask Steve, as an expert here?
I think I would just encourage people to proceed with their standard screening tests, and also proceed with following up with their cancer care if they're under treatment. I know some people have been hesitant to come in. I mean, the reality is that cancer doesn't stop for COVID, and we really need to continue to help our patients and also prevent further cases of cancer.
Yeah, I like that. Alberto, you buy into that? Cancer doesn't.
I would love to have the answer to how much the risk of dying, of getting infected and dying from COVID is carried by the person on whom I decide for starting first-line chemotherapy in the advanced setting or in the adjuvant. But I know that this is not possible, and we are called to a deeper insight in the cost-benefit analysis, having a determinant for which we do not know the impact. That is the difficulty I suffer from.
Yes. And in the end, we talked a lot about mortality, but the morbidity of COVID infection and potential long-term sequelae, and lung function, etc. I think that's something we haven't really explored and have fully understood yet.
Yeah, but actually, I'll say one last thing. I do think there is, some emerging data that cancer patients also can do okay. And so one thing I think is really important, and similar to what Dr. Ng said, is that we need to encourage our patients to seek care. Because one of the things I worry about is there's a fear of COVID, and so patients aren't showing up to get diagnosed. And that's actually really dangerous, because cancer will kill you, and we need patients to come and get in therapy and get diagnosed. Let us work through the issues of how to make those diagnoses, how to sort of modify their therapies that are the safest, and work with them to make those decisions. But if we don't have them show up to our doorsteps, then we can't help them. And we really want to encourage people to seek care and to ask questions, because if we don't, then we're doing them a real disservice.
Perfect. Yeah, cancer for our cancer patient is real, whereas coronavirus infection is a probability. It's a risk, but it's not there yet. And I think we covered all that. That's great. Okay, really, really great discussion. So for the audience, thank you for joining us for this program today. If you have any questions, please submit them in the Submit a Question tab located on the right-hand navigation bar. One of our expert faculty will respond to your query. To receive your CE credit, continuing education credit for today's program, please complete the evaluation located on the right-hand navigation bar. You'll then be able to download or print your certificate. And please join us next week when we launch Module 5 of the series, COVID-19 and GI Tumors, Update 1. Thank you again for joining, and thanks to our faculty members for participating.